So you go through 6 cycles of dosing, and PSA declines, and the patient tolerates it well. You get follow-up scans, and there's partial response. And the PSA is stable a few months out, and your patient says to you, well, what's the plan? I read about this Titan trial, and apalutamide is now approved. And I know this Latitude trial, and abiraterone's approved, and I'm reading about Enzamet and Arches.
I don't think that is a mistake to actually sequence patients, with existing data. Based upon Arches with RPFS improvement, I think the bigger question is, I don't think we truly know if doing that. I think most of us will be concerned about burning that bridge early on, right? And we have the data from that we published looking at the Wanaber Gravis data and the data from the ECOG data. Then clearly when you progress after docetaxel, putting you on another taxane is just not the right approach. Most people actually do better when they do an AR or a bio inhibitor. So, but the timing of that, I think, remains to me controversial. So I'm not opposed to that, but in fact, I even expanded a bit more. It really depends on what your PSA nadir is, because I do believe that your PSA within 6 months from therapy, whether it's docetaxel or an AR inhibitor, is going to be defining how well you're going to do over time. If you're not undetectable, I think that patient may be the one that may be more proactive and maybe put that patient on an AR inhibitor. If your PSA is undetectable, I feel more comfortable you're going to do better than the average patient. Let's just hold tight and see how you do over time.
But I do think Neil brings up a great point. Patients are much more educated now than they ever were. So they do walk into your office saying, hey, I read this trial, this trial, this trial. I just had this guy walk into my office 2 months ago. He's 53 years old. PSA was 400. His first PSA, he's got high volume disease. And he walked in saying, hey, I've read about this, 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 and this. So we've worked with our the med-onc guy that I use all the time. We put him on hormonal therapy. He's getting his 6 cycles, and then we're gonna put him on an AR therapy because he's young and wants therapy.
It definitely happens, and so really kind of throwing the kitchen sink at people is, for some people, probably the right thing to do. But on the other end of the spectrum, what about oligometastatic disease? What do you think about very few, and everyone takes a deep breath, those are for the high volume, very intensive patients, young guys that we want to be aggressive. What if you have 2 or 3 spots, maybe even just 1 or 2 spots of bone-only metastatic disease? Is anyone thinking about metastasis-directed therapy?
So talking about throwing the sink at someone, right? I think the background for me of that very important question is if you look at the STAMPEDE data, right? Remember that a STAMPEDE, that trial was never intended to differentiate people between low volume and high volume, right? And the arm of a STAMPEDE then look at ADT docetaxel against ADT docetaxel plus primary radiation to the tumor was a negative trial, right? It is when the trial is negative, then the investigators of a STAMPEDE decided to actually then use the charted definition and the latitude definition to define if, in fact, primary radiation to a prostate did have an impact in outcome, and comes to find out that yes, for low volume patients, regardless of whatever definition one uses. So that allows you to some extent to start thinking that maybe there are patients with really low volume disease that not only you can impact mortality, but also you may be able to render them free of disease. And Memorial has very compelling data that around 20 to 30% of patients in whom you throw the sink at them to some extent, they will be free of prostate cancer within 7 years. I don't know if that's good or not. So I think the questions then become, which we can discuss here, is how do we define oligo? Is it 1, 2, 3? Is it lymph node disease only? Is it lymph node and bone? And what is the best metastasis-directed therapy? And should we do metastasis-directed therapy alone, or should we follow sort of a STAMPEDE style and do treatment intensification? And in the process of that treatment intensification, whether it is 12 or 24 months, do metastasis-directed therapy. We have the SWOG data from Brian Chaplin, which is the trial that is looking at primary treatment. And we have the Metacure data, which is really actually randomizing patients also with oligomet disease to ABI, APA against ABI, including ADT, and then surgery for those patients with primary tumors in place, radiation therapy to the prostate bed, and metastasis-directed therapy. So these things are happening as we speak, and a lot of patients, talking about educated consumers, are coming asking you those questions right now.
That was a really great summary, Jorge. You did that really nicely. You know, at APCCC just a couple of months ago, this was a hotly debated issue, the definition of oligometastatic disease, the imaging behind oligometastatic disease, and all these ongoing trials, some smaller phase 2 trials that have already reported out, STOMP, et cetera. You know, you raise a great point in that it seems right now that what the biggest benefit is a delay to the onset of the requirement for ADT. And that's a good thing, I mean, because ADT is not a free lunch. ADT has a lot of associated toxicity to it, which historically, probably more so with urologists, we said, oh, well, you know, it's hot flashes and loss of sexual function, and we clearly recognize a lot of the more, you know, the plethora of side effect to it. So if you do metastasis-directed therapy and you can delay ADT and not put the patient at risk for the long term, I think that's quite the good thing. I get a little concerned about if we swing the pendulum back too much and we don't do the right trials. And so, for example, you know, taking out someone's prostate who has metastatic disease, that should really only be done in high volume, very experienced centers because of the potential for complications. Right. And then you made a really good point too about, you know, Chris Parker's paper in Lancet. You're absolutely right. The totality of the trial failed in radiation, but it was in the low volume group in a secondary analysis that showed the value. So we have to be careful about that as well.